This lecture is on gas exchange. Also, you may hear the concept called oxygenation. The exemplars for this concept are asthma, pneumonia, and chronic pulmonary obstructive disease, also referred to as COPD. Here are your learning outcomes for this lecture. So let's start with the definition. Gas exchange is defined as the process by which oxygen is transported to cells and carbon dioxide is transported from the cells. I'm not going to spend a lot of time going over the anatomy of the respiratory system because you all have had this before, but I do want to just remind you how important it is to remember the anatomy when learning about this concept. So just as a refresher, you have your upper respiratory system and your lower respiratory system. And your upper respiratory system is the part of the body that's going to warm and filter the air that comes in from the atmosphere, right? So you're going to have those nasal hairs, you're going to have the cilia, you're going to have the moisture that helps warm the oxygen as it comes into your body. Note here also that in the picture on the left, you can see your trachea, and the esophagus is right behind the trachea. So that's really important in nursing care to make sure you're aware of that anatomy because of the risk of aspiration that is in place. And then if you go on the right-hand side here, you're looking at the lower respiratory system, and that is where the gas exchange takes place, specifically in the alveoli, and we'll talk more about that. But I just want you an overview of the anatomy. So here's a picture of the lungs. You have on the left-hand side, you have an upper and lower lobe. On the right-hand side, you have upper, middle, and lower. I also want you to take note here of the trachea and how the tracheal branch on the right-hand side has a straighter, more direct angle versus the left-hand side. So what that means in nursing care, how it will impact your clients, is on the right-hand side, if somebody were to aspirate a foreign body, somebody were to swallow a coin, typically, not always, but typically we'll see that foreign body end up on the right hand, in the right lobe because of the straightness of the trachea. And so conversely, on the left-hand side, you have more of an angle. So when somebody has a pneumonia or an infection in the lung, it's sometimes more difficult to expectorate any secretions, any mucus out of that left-hand side because of the angle that the trachea takes going into that left lobe. Here are the alveoli where the gas exchange takes place. Notice how vascular this is. Typically in diagrams, the venous system is pictured in blue and the arterial system is pictured in red. Right? So the veins bring that unoxygenated blood back to the lungs, and it's at that alveolar capillary membrane that it drops off the carbon dioxide and picks up that fresh oxygen from the atmosphere. And it travels back to the left side of the heart by way of the arterial system and to all the other body parts. Surfactant is a fluid substance that lubricates those alveoli. And in disease processes where there's not enough surfactant, the gas exchange is affected or impaired. So you take in oxygen from the atmosphere. Y'all know that. The percentage of oxygen in the atmosphere is 21%. So in a normal functioning optimal gas exchange situation, you inhale oxygen from the atmosphere, and as the oxygen travels through the body uses up that oxygen, and that byproduct of cellular metabolism is carbon dioxide. So remember, too much carbon dioxide is toxic to the body. But in an optimal situation, as the carbon dioxide travels through the body back up to the lungs, it gathers more carbon dioxide and then goes out of the body through exhalation. So when you exhale, that carbon dioxide goes out. You do retain some of it, but most of it goes back out upon exhalation. But remember, this is a continuum, right? So if you think about breathing, if you don't have to, obviously you don't have to think about breathing. It's something you just do. And it's regulated by the autonomic nervous system. So we have receptors that sense what our carbon dioxide level is, and these receptors transmit impulses to the diaphragm and your intercostal muscles. And if there's too much carbon dioxide that makes the body too acidic, then the organs can't survive. But in an optimal situation, when the carbon dioxide level gets elevated, the impulses are transmitted and to the diaphragm and intercostal muscles. They contract and they pull in more air from the atmosphere. So remember that pulmonary ventilation has two phases. You have the inspiration, it's the active phase of ventilation, it's the involvement of those muscles and the thorax to bring the air into the lungs. And then the expiration is that passive phase of ventilation where the movement of air goes out of the lungs. So perfusion is what transports the oxygen throughout the body. It's the cardiovascular system. It's another concept that you'll learn more about. But the oxygen, again, comes in from the atmosphere, gets to that alveolar capillary membrane, and gets into the arterial system. But it's perfusion that carries that oxygenated blood to all your body tissues, to your organs, so that it can be used to help maintain life. So perfusion, the heart pumping, all the oxygenated blood down through to the tissues. I think you have learned this in the past, that oxygen diffuses from areas of higher partial pressure to the lower partial pressure, and that oxygen is transported by combining with the hemoglobin. So that combining is called oxyhemoglobin, and it is abbreviated HgBO2. Okay, what you really need to know from this slide is that the hemoglobin is what carries the oxygen, and in order for there to be good oxygenation, good gas exchange, then the clients have to have enough hemoglobin so that they can carry that oxygen. Perfusion is also what brings that carbon dioxide back to the lungs to be expelled from the body. So remember, carbon dioxide is that end product of metabolism, and it crosses that alveolar capillary membrane by diffusion and gets back to the lungs and is expelled out. Carbon dioxide diffuses more easily than oxygen across that membrane. So some things that you have to have for normal functioning of the respiratory system: you have to have what we call a patent airway, P-A-T-E-N-T airway. It's open, it's functioning, and we just spent several slides talking about the functionality of that alveoli and how the oxygen and carbon dioxide get diffused there. You have to have proper functioning of your cardiovascular system and your hematologic system, so good perfusion, and that then carries nutrients and wastes to and from the body. So we talked about factors that were important or essential to have normal functioning of the respiratory system in the last slide. So let's look at factors that influence that gas exchange or that diffusion of gas in the lungs. Things like changes in surface area. So in a normal lung, they say that if you were to cut open the alveolar capillary membrane there at that alveoli level, if you were to cut that open and spread it all out, it would be the size of a tennis court. So it's huge,
big surface area where that gas exchange is normally where it's normally taking place. But if you have something, a disease process or a surgical treatment that has altered the surface area, well, that's going to impact the ability for the gases to be exchanged. So if you have a surgery where part of the lung has been removed, or you have something that destroys the lung tissue, like a tumor or COPD. Atelectasis is when the alveoli collapse, and when that happens, that decreases that surface area, and the gas exchange is not able to be optimal. The second factor would be thickening of that membrane. That alveolar capillary membrane can be thickened by things like an infection. If there's pneumonia in the lung and there's an infection in the lung, there can be thick secretions that will impair that gas exchange. Pulmonary edema is another example of where you might have a thickened membrane and the gas exchange is not as efficient. What happens with pulmonary edema is the fluid backs up from the heart to the lungs and causes those membranes to thicken, and it's not as efficient. The last factor that influences the gas diffusion would be partial pressure. So remember, we talked about diffusion going from higher to lower partial pressure. Well, when you're in high altitude, like out in Denver and Colorado, the altitude is high, that the air is thinner, and it's more difficult to breathe. You get winded more easily. Toxic fumes like smog and air pollution also can change that partial pressure and make the gas exchange less efficient. So a couple slides on terminology. Pulmonary ventilation is that movement of air into and out of the lungs, and respiration is that gas exchange between the air in the alveoli and the blood in the capillaries. Just a little note here that when somebody's on a mechanical breathing machine, it's a mechanical ventilator, not a respirator. So just to kind of take note of that the ventilator is what moves the air in and out. So when somebody's on that mechanical breathing machine, they're ventilating the air in and out. There's no machine that can actually create the gas exchange at that alveoli level. We've talked about perfusion and how that's the oxygenated blood gets taken to the body tissues. Inspiration is the active phase of ventilation, and you will be using, it involves the muscle movement and the chest cavity to bring air into the lungs, whereas expiration is that movement of air out of the lungs and is more of a passive phase. You're going to hear the words hypoxia, ischemia, hypoxemia, dyspnea, and hypoventilation throughout this lecture, in terms of the concept of oxygenation. So hypoxia is insufficient oxygen reaching those cells. And someone can have acute hypoxia, or somebody can have chronic hypoxia. We're going to talk about what that looks like later in the lecture. Ischemia is insufficient flow of blood to the tissues, and that can be caused, that process, that insufficient flow, can result in hypoxia, or inadequate oxygen to the cells, and can cause cell death. Hypoxemia is actually reduced oxygen in the blood. Dyspnea is a symptom of hypoxia. It's when somebody's telling you they are having a difficult time breathing. And then hypoventilation is that decreased rate, or it could be depth of air moving into the lungs. It's often a result of hypoxia as well. So they're not being, hypo is low, right? So they're not being ventilated enough to have adequate oxygenation. The second learning outcome is to identify respiratory changes associated with aging. So we're going to take a look at that right now. So in an infant, actually in utero, before we even get to infant, as soon as the baby is born, their lungs go from fluid-filled structure. So in utero, they have the amniotic fluid in their lungs, to air-filled organs. So, I don't know if you've ever been present at the time of a birth of a baby. You always want to hear that first cry because it means that their lungs, means many things, but their lungs are actually shifting from or transforming from that fluid base to air. In a premature infant, a lot of times, if they're born early enough, they might not have enough surfactant, which we talked about in one of the other slides as being that lubricant that helps with the gas exchange at that alveoli level. So if they are born prematurely, sometimes they'll get synthetic surfactant as a medication. They have less alveolar surface area. Remember, again, we talked about what a large surface area, a typical adult alveoli capillary membrane surface area is. In the infants, there's less. So therefore, less, sometimes it can be less gas exchange or more inefficient gas exchange. All the infants' chests are pretty small, their airways are short, and therefore aspiration can be a problem in the infants. With infants, you will see on their vital signs, their respiratory rate is going to be more rapid than an adult. Their respiratory activity is more abdominal. So you will see their chest rise and fall, but when you're counting a baby's respirations, a lot of times I'll watch the abdomen go up and down. It's easier sometimes to count for the respirations for infants. You'll learn a lot more about infants and younger children in pediatrics, but this is the basic oxygenation or gas exchange information in an infant I want you to know about. In the older adult, you have or not you, in the older adult, you will assess a stiffer chest wall with loss of elastic recoil. They'll have weaker respiratory muscles, so that therefore their coughing will be less effective, which can put them at risk for infection of the lung or pneumonia. Their tissues and airways can become more rigid. Their diaphragm moves less efficiently. Hopefully this is kind of drawing a picture of, everything that we've talked about an effective or an efficient gas exchange and good oxygenation. The older adult and the changes that they're experiencing put them on that continuum where their gas exchange will be or their oxygenation will be less efficient. A lot of times you'll see older adults that have kyphosis, or it makes them look like they're leaning forward, and it's that little hump at the shoulders right behind the back and the neck. And that, along with possible barrel chest deformity that increases that anterior posterior diameter. We'll talk more about that, but think about that chest and that thoracic cavity and how that can perhaps make their oxygenation less effective, less efficient. They have changes to their bones as well. So the bony landmarks of the chest, of the thoracic cavity, are going to be more prominent in an older adult as they lose subcutaneous fat. Their nose changes. It kind of lengthens and the tip droops. So that can impact that upper respiratory piece of the respiratory system. In addition, the older adult has decreased surface area for that gas diffusion, like the infant. Their pulmonary capillary network can be decreased. Their alveoli, where that gas exchange takes place, can become more dilated and therefore less efficient for the gas exchange. And just their general ability to initiate that immune response to infection, like we talked about in the infection lecture, will put them at more risk for pneumonia. Couple that with the weaker respiratory muscles and not being able to cough as effectively. So these are some changes that how age impacts the gas exchange in an older adult. So let's walk through the nursing process a bit. Let's start with assessment. So when you have a client that comes in and you're assessing their respiratory system, their general health, you want to ask them questions about their disease processes. Do they have any more risk for impaired gas exchange based on their lifestyle, right? So do they exercise? Are they more sedentary? Do they smoke? What kind of work do they do? Are they around pollutants? Do they live in the city? Do they work in a factory? Or what's their home environment like? So those type of baseline history will kind of get to their risk for potential impaired gas exchange. You want to look at things such as cough. Do they have a persistent cough? Are they short of breath? A really good question to ask is how many pillows do you sleep with in bed? Because that can get to their short of breath when they lie down and they need to elevate their back when they're sleeping to expand that chest cavity. Do they have any chest pain with breathing? So you'll go into this in great detail in your health assessment class, but I want to make sure that you know that another piece of your assessment and your history is the physical findings that you're going to be assessing, right? So you're going to be looking at their vital signs. What's their oxygen saturation level? What's their respiratory rate, along with the rest of the vital signs? You're going to inspect them. I like to do this before I even put my stethoscope on the patient. You're going to look at their general appearance and note, are they having a hard time breathing? Are they using those accessory muscles? Or can you see the spaces between their rib cage kind of going in and out? We call that retractions. Can you see nasal flaring? So you're looking at them for their general appearance, their general work of breathing. What's their color look like? Are they breathing fast, which is tachypnea? Are they breathing slow, which is bradypnea? Bradypnea. WOB is work of breathing. Cyanosis is a late sign of hypoxia, and that is when they have a bluish color to their skin. Pallor tells me that maybe they're not being perfused well, or their oxygenated blood is not getting where it needs to be. And then you're going to put your stethoscope on them and listen to the lung sounds, okay? I put in our readings, in our lesson plan, a picmonic about some of the auscultating some lung sounds and what that means. So can you hear clear breath sounds throughout? And if not, what do the lungs sound like? And then I want you thinking, if I hear a wheeze per se, what's going on physiologically, right? Those airways, those bronchioles are getting smaller and smaller, more narrow. So that's why I hear that wheeze or adventitious breath sound. Remember a couple slides back, we talked about the definition hypoxia. Hypoxia is inadequate amount of oxygen available to the cells. So it's going to be very important for you to be able to assess your clients and determine whether the patient is hypoxic or experiencing or manifesting signs of hypoxia. And if they are they early manifestations or late manifestations? Meaning, basically what it sounds. Is it something that they've just started? Is it acute? Again, because hypoxia can be acute and it can be chronic, and you need to know where they are in that continuum to be able to treat appropriately. So somebody that comes in with signs of hypoxia are going to be manifesting compensatory signs and symptoms. So their breathing's going to be rapid, tachypnea. Their heart rate's going to be up, elevated, tachycardia. They're going to be restless. This is huge. One of the first signs is restlessness, because they're starting to get anxious because they're not getting enough oxygen to their brain. They're restless. They can tell that they're having some difficulty breathing. As it progresses, it can get into confusion. Again, they're going to have some pale skin. Their mucous membranes are not going to look as pink and shiny. It's going to be more white or pallor. Initially, with hypoxia, the blood pressure goes up. So you're going to have hypertension along with tachypnea and tachycardia. They're going to be restless and they're going to have pale skin. You're also going to notice increased work of breathing. They're using those accessory muscles, nasal flaring, and to breathe. And then you're going to hear, possibly, you're going to hear some lung sounds once you put your stethoscope on them. You're going to hear some lung sounds that don't sound like the patient is oxygenating efficiently. So you're going to hear things like wheezing or rales or rhonchi or crackles, and we'll get into those a little bit further, because you should be able to identify those lung sounds and then determine or be able to correlate that to what's going on physiologically. Late manifestations or signs of hypoxia include cyanotic skin. So if somebody is blue, they have been hypoxic for a while. Their body has not been able to compensate completely, or did compensate and is not doing it efficiently anymore. They're going to have stupor or confusion because the oxygen to their brain is not efficient, is not getting to the brain, or they're having some change in mental status. Their heart rate now is going to start going down. So instead of hypertension, they're going to have hypotension. Their heart rate, instead of being tachycardic, they're going to be bradycardic. So their heart rate goes down, their blood pressure goes down, and they can experience cardiac dysrhythmias because the heart muscle is not getting the oxygenated blood that it needs to function properly. So continuing with your assessment, we're going to look at some common laboratory studies that will assess our patient's gas exchange efficiency or their oxygenation. One of the very most important ones is called an ABG, or an arterial blood gas. And what this is there's a picture here on the left of the healthcare provider inserting the needle into the artery. You obtain some blood from the artery, and this measures the arterial oxygenation and the carbon dioxide level. Also the pH, the acidity of the blood. And this is very, very indicative and very informative to let us know how well the body is performing that gas exchange. It tells us the acid-base balance within the body. We're not going to go into a lot of details here. You will learn how to interpret ABGs in PathoPharm. We'll touch on it a little bit in Fluid and Electrolytes this course, but then you'll learn a lot more in Wellness 4. But know that arterial blood gases is an important lab study to measure the efficiency of the gas exchange and how well the body is oxygenating. Another lab study would be a CBC. A big piece of the CBC that you're going to want to pay a lot of attention to as related to the oxygenation concept is the hemoglobin. Remember, the hemoglobin is what carries the oxygen to the tissues, so we need to see what our hemoglobin number is. Is it appropriate? Is it within normal limits? Cardiac biomarkers are used so that we can see if there's been any type of injury to the tissues. So a lot of times a patient will come in with dyspnea or shortness of breath, and that can be a sign of not only pulmonary or respiratory system issues or oxygenation issues, but also perfusion or cardiovascular issues. So real important to get some cardiac biomarkers and check the status, see if the person's having a heart attack. And lastly, cytology study of the sputum. So if a client has come in and they have a suspected pneumonia, they're coughing a lot, we'll get in a sputum culture and sensitivity, and we talked about this in the infection lecture as well. And based on that result, we'll help our healthcare providers determine what type of antibiotic, if any, that we're going to administer to fight that infection. So some more diagnostic methods to assess the oxygenation status of your patient. Pulmonary tests that include endoscopy studies, such as a bronchoscopy. This can be done for a couple different reasons. They actually put a tube in the lungs. They put it down through the trachea. There's a camera on the end of it, and they can visualize the lungs. They can take a sample of a tissue or remove a foreign body through a bronchoscopy. A lung scan is also known as a VQ scan, and this is a scan that measures or assesses ventilation and perfusion. A lot of times they'll do this test when they're looking for blood clots. A skin test, like for tuberculosis, like you did to get into the program, radiography, chest x-ray. There's a picture of that on the right here. That is the most common, least expensive, least invasive diagnostic method in the pulmonary to assess the pulmonary status, and typically where healthcare providers will start if they're trying to figure out a problem. If the chest x-ray shows something or does not give us the information we need, then we can go into more detailed scans such as a CAT scan or an MRI. Cardiac testing is to, again, remember the pulmonary, the respiratory system and the cardiovascular system hand in hand, very interrelated, such as oxygenation and perfusion, very interrelated concepts. Cardiac cath, they will put a catheter up the groin, or sometimes they'll do it in the radial area on the wrist, and they're able to visualize the coronary arteries. They're able to visualize the heart and see if there's any blockages. Cardiac exercise stress testing is when the person walks on a treadmill and they're hooked up to an EKG monitor to assess how their body does under stress. Echocardiogram is like an ultrasound of the heart, and it'll show structural abnormalities or normalities of the heart. And then lastly is a Holter monitor, and that's basically a portable EKG. So if somebody comes into their healthcare provider and complains of dizziness or lightheadedness, or they're questioning if there's an issue with the rhythm of the heart, they can order a Holter monitor, and typically they'll carry these around for I want to say a 3-day period. It depends on what they're looking for. So one of the most common used diagnostic methods to assess gas exchange on your clients that you will be using is called a pulse oximetry. This is a non-invasive method that allows you to monitor the oxygen saturation in your client's blood. I believe you've already been exposed to this in lab, but a normal pulse oximetry is anywhere from 95% to 100%. You might see orders if a patient has chronic obstructive pulmonary disease, COPD, that we will accept an oxygen saturation of 90% or greater. And that has to do because the patients, and we'll talk more about it, but the patients that have COPD retain carbon dioxide, so they don't expel it all out, so their percentage of oxygen is not as high as someone who doesn't have COPD or somebody who hasn't been a smoker. But the pulse ox reading can be a really good trend to monitor your client's status. If someone starts having decreased levels of oxygenation of SpO2, it's called a desaturation. That does indicate gas exchange abnormalities. But make sure you realize that sometimes pulse oximetry can be unreliable. So if the perfusion is poor, if the extremity is cold, if the client has dark nail polish, so you need to be aware of the reliability of that test. And we will use our pulse oximetry readings to titrate oxygen. So I know that you'll be doing a case study the very first week of your clinicals where you will be looking at what that looks like. So if a client comes in with a certain oxygen saturation, let's say the client has a 98% oxygen saturation on 3 liters of oxygen, your order might be titrate your oxygen level to get your oxygen saturation number to above 93, 94, 95%. So you will bring the oxygen down, the oxygen that you're administering to the patient, as your oxygen saturations go up, and inversely. So if your client has a lower pulse oximetry reading, you may have to increase the oxygen. And if your client has a really good pulse oximetry reading, you may be decreasing that oxygen and monitoring or titrating it appropriately. Pulse oximetry does not replace an arterial blood gas. But again, it can be a good trend. Your arterial blood gas is that invasive blood test where you get blood out of the artery, and that is going to give you more precise information on your acid-base balance in the body. Capnography is used a lot in critical care or when someone is receiving CPR, and that measures the amount of exhaled carbon dioxide in the client. So it's used to monitor the ventilation, the blood flow through the lungs. So as the exhaled air passes through this sensor, it gives us an idea of what the CO2, how much CO2 is being exhaled. Thoracentesis, there's a picture here to the right with a man leaning over a pillow over a bedside table. This is the position that as a nurse you might need to assist your patient into if your healthcare provider is needing to perform a thoracentesis. Thoracentesis is done to aspirate any kind of fluid that would be accumulating in the pleural cavity outside the lungs, whether it be an infectious process or whatever the case may be. But the thoracentesis is when there's a needle that the needle gets inserted into that pleural cavity and some fluid and sometimes air can be expelled. So hopefully by the end of this lecture and your readings, you will get a good understanding of these different diagnoses for the oxygenation concept. When someone has a nursing diagnosis of impaired gas exchange, again, and I feel like I'm beating a dead horse, that's when the alveoli and the capillaries can't exchange the oxygen and carbon dioxide normally, okay? A lot of times, there's a lot of reasons that could be, but maybe it's because there's mucus or fluid in the lungs, right? Maybe the fluid is sitting in and around those alveoli so that the air you breathe can't get close enough to that capillary membrane to exchange oxygen for carbon dioxide. This nursing diagnosis can be applied for patients who have a pulmonary embolism or decreased cardiac output, because both of those conditions, remember, reduce the amount of blood flowing by those alveoli, which means less opportunity to exchange the gases. Okay? Whereas ineffective airway clearance occurs when there's something blocking the respiratory tract, whether it's completely blocking or partially blocking. What really comes to mind here is like if somebody swallowed a penny, a foreign body aspiration, it blocks that airway. Or maybe if the client has difficulty coughing up the secretions, that could be blocking that airway, so it's ineffective airway clearance. Another example would be bronchial constriction, so those little bronchial tubes are constricting, getting smaller and smaller, and that happens in the case of asthma. When you have ineffective breathing patterns, that is when there's actually physically something going on, that abdominal wall excursion, right? That inspiration, expiration, or both of them are not functioning optimally. So the patient can't be ventilated. So if the patient isn't ventilating, that's ineffective breathing patterns. So the patient's not, again, the whole concept is the same. The patient's not getting enough oxygen to the cells. The breathing is inefficient. So we're looking at something like trauma, surgery. Heart failure is a good example. Drug overdose is a really good example of ineffective breathing patterns. So pay attention to these diagnoses, get it straight in your head, kind of the difference and the pathophysiology behind between all three of them. You can also have alteration in oxygenation as your etiology, as evidenced by these three examples. These are by no means all-inclusive, but wanted to give you an idea of how alterations in oxygenation can be the cause of other issues. Anxiety related to activity intolerance related to the imbalance of oxygen supply and the demand of the oxygen supply and demand. Imbalanced nutrition, less than body requirements related to difficulty breathing. So I hope this slide kind of clears up the different diagnoses, and I think by the end of this lecture, you'll get a light bulb that'll click on the differences in these. So some nursing interventions to promote optimal gas exchange are listed here. A lot of what we do is teaching our patients about good health promotion. There are some things that I've listed here, like teaching your clients about pollution-free environments. A lot of people that have lung conditions are very savvy about when they can go outdoors and when they should stay indoors. A lot of times on the news, they'll say it's an orange day or a red day as far as the air quality. And our clients that have issues with breathing, if the pollution is high or if the pollen is really bad and it can impact their breathing, then we want to encourage them, educate them to stay indoors. Vaccinations, there's vaccinations for the pneumonia vaccine, flu vaccinations. We want to make sure that they're drinking adequately to thin secretions, that they're eating the right foods. As far as promoting comfort, we want to encourage the patients to sit where they're feeling comfortable. Sit up. If they're having a hard time breathing, one of the very first things that we'll do as an independent nursing intervention would be to sit the head of the bed up. So what that does is it opens up, it allows their lungs to expand. It opens up that thoracic cavity so that they can have more room to expand their lungs. And sometimes we'll have them lean forward to optimize that lung expansion even more. So a lot of times people that have difficulty in oxygenation will sleep with their head of bed elevated. Couple pillows behind them. Remember I talked to you about when you're collecting health history information. It's a good question to ask. How many pillows do you use when you're sleeping? And that can indicate if they're having issues with gas exchange, with oxygenation. So that's a good, again, independent nursing intervention is to promote their sitting or promote comfort based on how they're sitting. Other things we're going to talk about in a little bit more detail are some proper breathing strategies and techniques to promote gas exchange. We're going to talk a little bit about encouraging the use of controlled coughing, maybe using the incentive spirometer to promote that gas exchange. On the right-hand side, the clinical nursing skills for gas exchange, I took this right from your textbook. Some of these positioning is the comfort that I just talked about. The nebulizer is going to be one of your dependent nursing intervention. So meeting oxygen needs with medications. So a nebulizer or bronchodilators, those are dependent nursing interventions. And I think you've heard it already, but just to make sure that you have, independent nursing intervention is something you can do without a healthcare provider's orders, like sitting someone up, raising the head of the bed. Dependent nursing interventions are things that you need an order for. You need a healthcare provider order to administer a nebulizer or administer a bronchodilator that's going to optimize the gas exchange. Airway suctioning, sometimes clients will need tubes to help them breathe, whether that's an endotracheal tube or a tracheostomy tube. And you will learn more about these in Wellness 3. Mechanical ventilation management, if somebody is on a ventilator. These are nursing skills that are going to optimize gas exchange that you will become very familiar with. So this slide just dives a little bit deeper into those bullets from the previous slide on how you as a nurse are going to intervene or promote optimal pulmonary function to get your client to have optimal gas exchange, right? So the goal is optimal gas exchange, good oxygenation. Um, so things like healthy lifestyle, making sure people don't smoke. If they do smoke, helping them with a smoking cessation plan. The pollution-free environment we talked about earlier. If someone has to go out into the environment that has pollution, which typically they do, they need to know how to avoid their triggers, and that's real important with asthmatics, and we'll talk more about that. Those vaccinations that I talked about a little bit earlier, pneumococcal vaccination, the influenza vaccination, those are really important for people, for all children, all people basically, but those at high risk, it's extremely important. So people who smoke, people that are over the age of 65 that have asthma, that are at higher risk, we want to make sure that they're getting these vaccinations so that we can prevent them from having those complications and inadequate gas exchange or inadequate pulmonary function. So some promoting comfort strategies or interventions. Positioning the client for maximum ventilation. So that's going to be in the Fowler's or semi-Fowler's position. You see this person in the picture here, he's kind of leaning forward. He's sitting upright, trying to promote the best gas exchange that he can have. If someone is exhibiting signs of impaired gas exchange, if they're having dyspnea, they're having a difficult time breathing, the very first thing you want to do is sit them up. That's an independent nursing action. You want to sit them up, complete a focused respiratory assessment. You're going to want to promote deep breathing, promote coughing if that individual needs that, possibly use supplemental oxygen as it's prescribed. You want to always stay with the client and provide emotional support because they're going to be anxious. If they can't breathe, they're going to have increased anxiety, which can then cause more inefficient breathing. So you want to support them emotionally. You want to encourage them to cough to promote airway clearance. You may have to suction an individual if there's a lot of secretions that are blocking the airway. Another really important activity is what we call pacing physical activities. So allowing for rest, really, really important to educate the patients that if they become short of breath when doing too much, or just they could become short of breath when walking across the room, that they need to stop and sit down and rest, make sure they're oxygenating well enough before they continue with their activities. So pace those physical activities to allow for rest and allow for proper oxygenation. So promoting proper breathing, there's some nursing interventions that we can use to help our clients promote proper breathing. Incentive spirometry is one. You can see a picture here on the right-hand side of this device. It's a tool that a lot of patients receive as soon as they go in the hospital, certainly those that have had surgery. And the purpose of it is to promote lung expansion and keep those alveoli expanded. And how it works is you instruct the patient to take a deep breath and then blow the breath out of their mouth. Place the mouthpiece in their mouth and put a good seal on it, and then they suck in like they're sucking in a straw. A lot of times that gets confused, but the correct way is to place the mouthpiece in the mouth and then suck in the air. And what you are going to instruct them to do is there's a little piston that in the diagram here is blue, and it rises with each deep breath that a patient takes. So you're going to set a goal and have them try to, as they're sucking in, that piston will go up. So you want them to hold on to that breath and hold that piston up to whatever that goal is. Now on the right-hand side there, you're going to see a little blue ball that has two arrows. There's like two arrows to the right of it. When they are using this incentive spirometer, you want that ball to float in between those two arrows, and that's going to optimize this incentive spirometry mechanism. So typically I will tell them, my clients, again, I'm pediatrics, so they're watching a lot of cartoons. I'll tell them, when the commercial comes on in between your cartoons, I want you to do this and I want you to do it 10 times. So they'll do that, and promote that lung expansion. And this machine is a personal machine. They'll take it then home with them. And if it's somebody who has had surgery, we ask them to continue to use this incentive spirometry once an hour, do it 10 times until they're up and moving and expanding their lungs, like they were pre-surgery. Another proper breathing promotion technique is called pursed lip breathing. And what this is it slows the expiration, and by doing that, you're going to improve the air exchange and decrease dyspnea. Right? So you may have seen people doing this that are in pain, childbirth. What you want them to do is to try to relax, breathe in through their nose in 2 seconds, 3 seconds, keeping their mouth closed. And then when they breathe out, they're going to want to breathe out through pursed lips, like they're whistling, right? So, and that again slows that expiration. The diaphragmatic breathing technique is described in your Hinkle book in chart 17.5. But basically what that is, again, it's to promote the lung expansion as well. You get them in a semi-Fowler's position, prop them up in bed with some pillows, and then have them put their hand lightly on their lower ribs or their chest area. They're going to breathe out gently until they can feel that their ribs kind of go inward or sink down, and then take a deep breath through their nose and mouth, and then feel that their stomach, their abdomen is going to rise as their lungs fill with air. They hold that to a count of 5 and then exhale and let out all the air through their nose and mouth. So they do that. We tell them to do it 15 times and practice that. Again, really important to teach them that before they have surgery so they can do it after. So those are just some examples of of some breathing exercises and things to promote proper breathing. Coughing is a cleansing mechanism for the body. You can have a dry cough, which means they're not coughing anything up. There's no secretions, or a productive cough, which is sputum or mucus that they're actually coughing up out of their lungs. Voluntary coughing is where you have the client cough on demand. So you'll say, take a deep breath and give a good cough. Okay. And it's really most effective if you can get them to take a deep breath first, because then when they take a deep breath, that air that they breathed in will kind of push that sputum around and help them expel it. So a lot of patients that are in bed for a long period of time, or even a short period of time, we will go in. Our nursing interventions will be something like turn, cough, and deep breathe every 2 hours, so that you're turning them so they're moving around. They're coughing, deep breathing every 2 hours. So that's done on a schedule. It's voluntary coughing. Okay. Involuntary coughing, again, can be a dry cough or a productive cough, but it's just something that is done. You don't schedule that. It's important for you to understand the cough medications and what the purpose is. So your expectorant is a medication that will allow the patients to cough up the sputum. So if the patient has an upper respiratory infection, has the flu, has something that has caused them to have a lot of secretions in their lungs, we want to give them a medication that is ordered by a healthcare provider. That's a dependent nursing intervention. We want to give them a medication that's going to allow them to expectorate, or to clear that airway, cough that sputum up. as opposed to a suppressant. So a cough suppressant works on the center of the brain that controls coughing, and it will help decrease the coughing amount. So you never ever want to give a suppressant to somebody who has a productive cough, because that is suppressing, obviously not allowing the patient to cough that and clear it out of their lungs. So an expectorant would be more appropriate. A lozenger is a way to soothe the throat. It doesn't work on the brain, but a lot of times it can help the clients that have like a tickle in the back of their throat, or help them ease the cough, if you will. So some dependent nursing interventions, or nursing interventions we can do based on our healthcare provider orders, would be things like administering medications. I wanted to make sure you realize that I put administering medications and monitoring the effectiveness of these medications. So that means before you administer the medication, you want to do a good assessment, see what their oxygen saturation is, see what their respiratory rate is, hear what their lungs sound like. And then after you administer the medications, you're going to want to repeat those assessment techniques so that you can see if what you did worked, monitor the effectiveness. The first line of medications for someone that is experiencing difficulty breathing or shortness of breath, that's related to bronchoconstriction, is going to be a bronchodilator, right? So it is something that's going to open up their airways. It's a beta-2 adrenergic agonist agent. So like an albuterol inhaler, an albuterol nebulizer, something that, so with these clients that are having difficulty breathing, their airways are closing, they're constricting. So you want to open their airways. Until you open their airways, the other interventions that you're doing are not going to work. So bronchodilators can be administered through a MDI or an inhaler, can be administered through a nebulizer. And they are indicated when those bronchioles are constricting, if the patients are having a hard time clearing the secretions, they can't cough those secretions up. There is a picture here of an inhaler with a spacer, and then a picture with a nebulizer with kind of a peace pipe, and a nebulizer with a mask. So these are different ways that you can administer these bronchodilators. When you are educating them, you want to make sure that they know that they are to take slow, deep breaths through their mouth, hold for a few seconds, encourage coughing, and monitoring the effectiveness of that treatment after the medication gets into their lungs. So another medication would be an anti-inflammatory agent, something like a corticosteroid, because you'll find, and we'll talk more about the exemplars, our pneumonia, asthma, and COPD, that you will find that these disorders, these disease processes, have inflammation in their airways. So we will want to use an anti-inflammatory to decrease the inflammation. If the oxygenation issue is due to an infection, due to pneumonia, then we will need to administer antibiotics as ordered. If it is an allergic or anaphylactic reaction, an antihistamine might be appropriate. Antipyretics if the client has fevers, and decongestants to minimize that congestion. Another dependent nursing intervention, which needs a doctor's order or healthcare provider order, is called chest physiotherapy. Chest physiotherapy includes postural drainage, which I'll talk to you about on the next slide, but it uses chest percussion and vibration to help with secretions so that the patient can get rid of those secretions out of their lungs. And This cute little guy here's got the vest on. So the vest gets applied almost like a life jacket, and it hooks to a machine and vibrates the chest. So it allows that vibration to loosen up the secretions so they can expectorate it. It also inflates and deflates rhythmically, so helps with breathing training. And again, the goals of these would be to improve ventilation, to remove the secretion, and just, basically improve the efficiency of the respiratory muscles. This is a picture of postural drainage. Again, you need an order for this, and typically in hospitals, the respiratory therapy will do this, but it uses gravity to help remove those secretions. So you make sure that the patient is able to lie down in these types of head down type positions before you do it. You need an order. And it just helps with, it uses that gravity to help drain the secretions from the lungs. And you would never ever leave somebody in this position for a long period of time. It's just a short treatment time period, and then you turn them back up in the semi-Fowler or Fowler's position so that they can breathe better. But it's really, it's helpful in those lower parts of those lungs where the secretions can accumulate in that lower part. So, because if somebody sits up, with gravity, then those secretions are going to sink down to the lower part. So you tip them basically upside down. You help them with that drainage based on their positioning. I really like this slide because I think it summarizes a lot of what we just talked about on our nursing interventions. If you are caring for a client with impaired gas exchange, these are the things you want to do almost in the order in which you want to do them. So somebody's complaining of dyspnea, shortness of breath. You position the client for maximum ventilation. You sit them up in a Fowler's or semi-Fowler's position. That's an independent nursing intervention. You complete a focused respiratory assessment. So you inspect, you auscultate, you listen to their lungs, you check their oxygen saturation, you check their respiratory rate, you look at them to see if they're having work of breathing, using any accessory muscles to breathe. You promote deep breathing, so you have them cough, deep breathe, and as a dependent intervention, you provide supplemental oxygen as prescribed. So if the oxygen saturation, if there's an order that says keep oxygen saturation above 95%, administer oxygen via nasal cannula to keep the oxygen saturation greater than 95%. Then you put the oxygen or pulse oximeter on the pulse oximetry meter on the finger. You assess them and you put the oxygen on and increase it until you can get to 95%. Okay. You stay with the client, provide emotional support because a lot of times they're going to be anxious because they can't breathe. And then you promote that airway clearance by encouraging them to cough. And sometimes you actually have to put in a catheter in, a suction catheter, and suction their oral pharyngeal cavity, which is not pleasant for them. In the last couple slides for nursing interventions, I've talked about administering supplemental oxygen. So let's talk about that. So when your clients are in need of supplemental oxygen, which means they need greater than 21% in order to have that oxygen in the blood, decreasing their work of breathing and reducing the stress on the heart, you administer oxygen. Oxygen is a medication. It needs an order. Here in this slide, you'll see a couple different pictures I wanted to point out. On the left-hand side, there is a picture of the oxygen flow meter, which is in green, and then medical air is in yellow. Sometimes students get confused on this. The oxygen devices that we're going to show you in lab and that you're going to learn about get hooked up to the green flow meter on the left there. The yellow flow meter is a medical air, and we use that for compressed air, like for the ventilator or some other medical devices. You never hook the oxygen up to the yellow because they're not actually going to be getting oxygen if that's the case. So the green flow meter is the oxygen flow meter that you hook your supplemental devices up to. The middle picture is a picture of a portable oxygen tank. You would never keep this upright without a canister holder to prevent it from tipping over, because if that oxygen tank were to tip over, it could potentially explode and almost act like a missile. On the right hand side here, you'll see this is a suction canister. Just wanted to make sure you're aware of that. The oxygen tubing, oxygen cannulas, they do not get hooked up to that suction. The suction is, you'll learn that later, but it's to clear the airway with a catheter, suction catheter. So oxygen tubings get hooked up to the green flow meter or portable tank, which should never be standing just by itself there. It should be secured in a canister or a holder. So why you would use oxygen therapy, when you would use oxygen therapy. This is a repeat information from earlier, so obviously I think it's very important. Remember, hypoxemia is that decreased arterial oxygen in the blood, and hypoxia is a decrease in the oxygen supply to the tissue and the cells. So severe hypoxia can be life-threatening, so we want to make sure that our assessment skills are good and we can identify when somebody is in early hypoxia or in late hypoxia. There's a couple links here that show you some videos on what it looks like to have work of breathing, what respiratory distress looks like. Real important for you to understand and be familiar with. When the patient comes to you with these type of symptoms, we will probably, we will be needing to supply supplemental oxygen.
We're going to review these different oxygen delivery systems in the next several slides. Want you to be aware about oxygen toxicity. It can occur, it's not that frequent, but these are the symptoms that may happen if somebody is receiving too much oxygen.
Okay, so this is a chart of the types of oxygen delivery devices that we're going to talk about in a little bit more detail in the next couple slides. But I wanted to show you how much oxygen is delivered with each device. Up the top there on the green, you're going to see the fraction of inspired oxygen, which is FiO2. That's the amount of oxygen that's delivered with each device when the flow meter is set at the correct rate. Room air has 21% oxygen. The nasal cannula is a basic oxygen delivery device that can deliver anywhere from 1 to 6 liters of oxygen. Here at the very first column, I have 1 to 2 liters of oxygen will deliver 24 to 28% FiO2. This is a basic device that we as nurses can put on our clients if they're experiencing dyspnea without a order at first. So someone's complaining of a difficult time breathing, your assessment says they need supplemental oxygen, you sit them up in the bed to try to expand their lungs, and then if that doesn't work, you can put them on a little bit of oxygen, 1 to 2 liters, without an order at the time. You go back then and get an order after you've done that. If the client needs more oxygen, if that doesn't work for them, you then go up this chart, if you will. Venturi mask is a device that administers anywhere from 24 to 40%. The flow meter will be set on 4 to 12 liters respectively. And then the nasal cannula, it's the same device that you use to give the 1 to 2, can be increased up to 6 liters, and it will deliver anywhere from 32 to 44%. If the nasal cannula is not working at that 6 liters, then you apply a simple face mask, which can get up to 60% of oxygen on 8 liters. The next device is called a partial rebreather, which we'll talk more about in the next couple slides. And then the last column here is your non-rebreather. And the non-rebreather is the only way to deliver oxygen at 100% without putting a tube into someone's lungs and putting them on a ventilator. So this is a picture of a gentleman with a basic nasal cannula. in his nares. This nasal cannula, again, can deliver up to 44% of FiO2 if the flow meter's at 6 liters. You don't want to give more than 6 liters via nasal cannula. If your client needs more FiO2, then you change the device. So the nasal cannula can be hooked up to a portable oxygen source. Some good things about it are that people can eat while they have this device on. They can talk, they can walk around. It's usually well tolerated and easy to apply. One of the deficits or disadvantages of this is it can dry, and it does dry the nasal mucosa out a good bit. So if a person is on this, certainly at a higher flow rate, we typically hook them up to some humidity to try to limit that dryness. Um, Depending on how fast and how deep the person breathes, will vary the amount of oxygen that they're actually getting, that FiO2. And this tubing can fall out of the nose. It can get dislodged from the flow meter. Well, all of them can at that point. But you just want to make sure, again, you're using your assessment data to make sure that it's delivering the oxygen that we want it to. Here's a picture of somebody with a basic face mask on. It delivers 40 to 60% FiO2 with the flow meters from 5 to 8. You never want to deliver oxygen with this face mask less than 5 liters because it can cause them to retain CO2. Typically, we keep these face masks on only short term. They are easier to apply than a nasal cannula, and some people tolerate it better. Some people just don't want anything in their nares with the nasal cannula. But others have issues with claustrophobia or anxiety. Obviously, you can't drink and eat with this mask on. It's sometimes difficult to talk with it on. And then there is some pressure and moisture that can accumulate under the mask. So you need to really be assessing for skin integrity and check to make sure that they don't have skin breakdown with where that mask hits the face. Here is the Venturi mask. It delivers 24 to 60% oxygen, and the flow rate that you set your flow meter on, it goes anywhere between 4 to 12. And these little adapters that go on the bottom of the face mask there will have written on the adapter what flow rate you set the flow meter on and how much oxygen it's going to deliver. This is the device that delivers the most precise oxygen concentration. You can regulate it the most precisely. Patients, again, with the face mask, they can have anxiety and claustrophobia, and they also can't eat or drink with this as well. And it tends to be a little bit expensive, but it is the most precise way. You want to make sure that those little holes, just like the face mask on the side, are open so that they don't retain the CO2. Typically, respiratory therapy sets these up, but you want to make sure that you know how to find them and what to do with it. Has the same kind of disadvantages with the moisture and the possible skin breakdown as the basic mask. So the partial rebreather mask looks like a face mask, but has a bag attached to it. That bag is called a reservoir bag, and it collects the first part of their exhaled air. The rest goes through those side vents. They're called exhalation ports. Those are on the side there. The air in the reservoir is mixing with 100% oxygen, so it gives them a little bit of that CO2, but it mixes with 100%, which is why it's called a partial rebreather. What you need to know about it is you need to make sure that that bag stays inflated and the mask fits tightly around the patient's head, and it can deliver up to 75% of the FiO2. Same concerns of the other face mask, and as far as the skin integrity and the claustrophobia. And you need to make sure again that that bag stays inflated um, when in use. So the non-rebreather mask is the mask that delivers the highest concentration of oxygen to a spontaneously breathing patient. So what I mean by that is if someone is intubated and they're not breathing on their own, they will be ventilated. They will have a ventilator on, correct? So this delivers up to 100%. There are valves on either side of the masks there that prevent them from rebreathing the exhaled air. So the bag is filled with oxygen. So they're taking in oxygen from the atmosphere and getting oxygen from the flow meter as well as extra oxygen from the bag. So those side vents are two-way valves, and the oxygen comes in and the carbon dioxide goes out. The big takeaway from this you need to know is that you have to have that bag inflated in order for that to deliver the 100%. I mentioned here the idea about oxygen toxicity. It happens rarely, but if we are administering oxygen at 100%, we need to monitor and make sure that our patients don't become toxic from our oxygen. You will never administer this type of face mask. You'll never administer oxygen as a student without your instructor with you, but you always want to make sure that you're evaluating, monitoring, and adjusting accordingly. The last slide here for the oxygen delivery devices are these oxygen tents, if you will. And these are non-precise oxygen delivery device. You can see we do use it in children and pediatrics to kind of get that oxygen just is blowing by their face. On the picture on the left shows more of an oxygen face shield. Use that in recovery a good bit, again, just to blow the oxygen by their face. It does not deliver a precise amount of oxygen, but it's just another method to provide if someone won't keep the mask on, or you have extenuating circumstances. You will have clients that will be prescribed home oxygen. They can have these portable devices in a couple different forms. The most popular that I see are the backpack or arm slings. Almost you carry it like a purse. My brother-in-law actually has one of these. And then the blue picture here on the left is more of the bigger device that they connect up to when they're sleeping, right? So you want to make sure that the clients that you're educating know not to smoke around these oxygen devices, not to use a stove. I know there's a picture in here of a lady holding onto a portable oxygen. She's making cookies. Hopefully she did not make those cookies with the oven sort of while she had her oxygen on. We want to prevent that. Sometimes synthetic fabric can cause static electricity and cause a spark. We want to avoid that. And oils, again, anything that possibly could cause it to ignite. We want to make sure we are uh, educating our clients on that if they have home oxygen. So atelectasis is closure or collapse of the alveoli. And we see this with patients that are not getting up and moving, they're immobile, whether it's after a surgery, abdominal surgery, thoracic surgery, where they don't want to take a deep breath, or they're just lying in bed, immobile for whatever reason. Um, and the symptoms that they experience are usually they complain of shortness of breath, they have a cough, they have increased work of breathing. When you listen to them, when you auscultate their lungs, sometimes you hear crackles because those alveoli are not inflating and deflating the way a normal gas exchange will take place, a lot of times you'll see atelectasis on x-ray before the patient even starts exhibiting symptoms. So it's a very insidious type of presentation, right? So it's not a sudden, they don't all of a sudden complain of having a hard time breathing or cough, but it's more of a gradual occurrence as those alveoli, more of them start collapsing or start closing. The oxygen saturation, your pulse oximetry, can also exhibit a low number, so less than 90%, again, indicating that the gas exchange is not taking place at the alveoli because they're closed or collapsed. This is very a good example of how our nursing interventions can prevent this. Okay, again, it's caused, or a lot of times it happens when people are immobile. So making them mobile, turning them a lot, having them use that device that we talked about already, that incentive spirometer, having them take those voluntary deep breaths. So deep breathing, trying to get rid of their secretions. So whether that's suctioning or having them expectorate on a forceful cough. And sometimes they'll need an inhaler to try to, if depending on what the cause is, to kind of get those bronchioles open and open up, kind of force those alveoli to start inflating again. So your Hinkle book talks about the ICOUGH multidisciplinary approach intervention program for atelectasis. Atelectasis is commonly encountered abnormality when we're talking about gas exchange. Again, it's that closure or collapse of alveoli. We as nurses need to know about the treatment, about atelectasis, about how to treat it and how to prevent it, really. So the goal to treat it is to improve that ventilations, to remove the secretions that possibly could cause the alveoli to collapse or close. So the first line measurement is that deep breathing exercises, incentive spirometry, positioning, getting them out of bed, making them walk around, making them more mobile, right? So understand the atelectasis, understand the treatment and the prevention methods. So pulmonary embolism is included in this concept of oxygenation because when a pulmonary embolism or a PE occurs, there is extreme impaired gas exchange. So let's talk a little bit about what it is and how we manage it. A PE occurs when there's an obstruction of the pulmonary vasculature with an embolus. It can be a thrombi, it can be a blood clot, an air bubble, or fat droplets. People at risk for developing PEs are those that have been in a trauma, motor vehicle accident, those that have just undergone surgery, had a pregnancy, people that have cardiovascular heart failure issues, the older adult, and those who have prolonged immobility or do not move around a lot. So a thrombus is a blood clot, and most commonly pulmonary embolisms are due to a blood clot. When that blood clot either partially or completely obstructs the pulmonary artery or any of its branches, the dead space, the alveolar dead space, is increased. So that what that means is there cannot be gas exchange in that dead space. So we have impaired gas exchange. The area that is receiving little or no blood flow is the area that has either absent or impaired gas exchange. And this is a medical emergency. Death from an acute PE commonly occurs within an hour after the onset of symptoms. So it's real important as nurses to be able to identify what a person looks like when they're having a PE and how to manage that. So what's somebody going to look like who comes in with a pulmonary embolism or who has a pulmonary embolism. It'll really depend on the size of the clot and the area of the pulmonary artery that is occluded. But dyspnea is the most frequent symptom, and the duration and intensity of that dyspnea depends on the extent of the embolization, right? So embolization refers to the passage and lodging of the embolus within the bloodstream. So remember the concept of gas exchange. We need that blood flow to complete the gas exchange. So if the perfusion in this example has stopped or is occluded, then we're going to have the issues. So they have dyspnea, they have tachypnea, they're breathing fast, they have this sudden pleuritic substernal chest pain. Unlike any other, they're very anxious and apprehension sets in because they cannot breathe. They're very scared. Their heart rate goes up. They can have coughing, which possibly can include blood, coughing up blood. That's hemoptysis. They will be sweating or diaphoretic, and syncope will happen, so can happen. Syncope is temporary loss of consciousness because the patient is not having sufficient blood to the brain, so they're passing out, if you will. It is a medical emergency. You start CPR, you administer supplemental oxygen. It will be very important to provide anticoagulation and thrombolytic therapy per the healthcare provider's order. And as nursing managements, we want to minimize the risk of a PE. So we want to get people up and moving. We want to administer Lovenox or heparin or whatever anticoagulant has been prescribed post-surgery or post-trauma. We want to try to prevent that blood clot from forming so this PE doesn't happen. Want to manage pain so that people after surgery can get up and walk around and hopefully prevent complications. We're going to manage the oxygen therapy and hopefully relieve the anxiety of our patients. That concludes the lecture on the concept of gas exchange, also known as oxygenation. Please take note these interrelated concepts and how they affect oxygenation, gas exchange. I think we've talked at good length about them, but make sure that you understand this concept and how the other concepts relate to it. Thank you.